Cool. And now it's recording. Okay, perfect. Hello, everyone. We have three great panelists with us today. Our topic today is going to be clients in the criminal justice system, and how this will kind of go whenever we have a DiversiWe panel discussion is I'll just be asking questions that I sent out to our panelists about a week ago. And then if there are any questions throughout the session that anyone listening wants to add in, feel free to type them in the chat, and I'll kind of be looking at the chat throughout the whole time. And then we'll have time for individual questions at the end, as well as I'll have all of you participants fill out a survey about just ways we can improve and things like that. So let's go ahead and get started. If any of you panelists want to, I don't really have a specific order of who wants to go ahead and just maybe introduce yourselves, say a little bit about what you do, just so everyone kind of knows what lovely people you are and who we have here today. So I don't know who wants to go first, but feel free to just hop off the mic, super casual. We just want to learn about y'all.
I'll go first. My name's Jamie Klein. I have a bachelor's in criminal justice from UNC, and then I also have a master's from clinical and mental health counseling from UNC. I'm also a licensed professional counselor, so I am fully licensed. I'm a nationally certified counselor. Specifically, I work with clients who are high profile clients and high risk clients, meaning they are within the criminal justice system, whether that be on probation, parole, under intensive supervision. So usually that means convictions with sex offenses or economic crimes. I do evaluations for the courts, attorneys, to evaluate risk assessments and needs, depending on what the clients need. So I have two private practices. I am currently in the process of buying forensic evaluation and treatment services. That's where I do my offense specific work. And then I work with families and couples in reunification with my vivid healing therapy practice. So I do a couple different things. So.
I guess I can go next. I'm Dr. Julie Streakin. I'm an assistant professor of psychology with Regis University. And my area of interest is how marginalized populations make sense of experiences of victimization, particularly intimate partner violence and sexual assault.
Hello, my name is Dr. Rebecca Rivera Serrano. I also teach at Regis. I also teach at CSU Global and MSU. I was in the criminal justice system for about 25 years. I was a probation officer. I worked for the Department of Justice. I worked pretrial and diversion as well. So my gamut of experience is pretty diverse. I worked with sex offenders, domestic violence offenders, juveniles, females, and all of my research is in correctional education and how do we reduce recidivism through education, and particularly post-secondary education. So I'm very excited to be here. Thank you for inviting me.
Awesome. Yeah, thank you all so much for being here. And I'm personally really excited to learn from you all. So I feel like I just want to jump in with the first question that I have. And then once again, super casual, feel free to jump in as you see fit. But the first question I have is, what has your experience been in working with or conducting research on clients involved in the criminal justice system?
Yes, I'll start. So my experience has been providing crisis counseling to survivors of intimate partner violence and sexual assault, and also conducting research on this same population. So when I was doing crisis counseling, I provided referrals to law enforcement and the court system. I've also advocated for clients with law enforcement as well.
I can go next. I worked with clients for 25 plus years in regards to helping them to follow their court orders, but also really working in habilitation and rehabilitation to address the trauma that drives their criminogenic behavior. So a lot of holistic approaches, really outside of the box thinking when it comes to traditional court systems. I worked probation for 13 years. I've worked gangs, drugs, sex offenders, domestic violence offenders. I think most currently what I work with is helping men and women integrate back into the community through education and trauma-informed care.
Yeah, so actually, I think there's quite a bit of overlap in terms of research and integration of treatment. So like I had mentioned, I primarily work with offense specific, meaning right now, clients who've been convicted of sex offenses. So my primary focus is understanding the holistic approach of evaluating domains, their risk, needs, trauma-informed care, to be able to actually scale into the treatment plan and execute it in a way to where while they're on probation and on parole, we can see those progress in those domains. So I do a variety of assessments. So VASER and SOTIPS risk assessments, that's something I'm very familiar with. We use SOARs depending on the crime. So if it's child abuse, sexual images, or if it's a hands-on offense, if they have a significant criminal history, those are all varying factors that can increase risk. So it just depends on how much supervision they'll need, how long they'll be in treatment. I've very much been working with integrating the trauma-informed care from clients' trauma, in addition to really compiling in victim empathy, psychoeducation for those clients around victim-informed care. That really goes into the victim empathy pieces that we work on in treatment. The evaluations are pretty separate from treatment. I typically go in and have a clinical interview. I administer all the assessments in terms of identifying their intelligence levels. I'm not explicitly trained in like the WAST or anything of that nature, but we use like the Shipley to be able to assess that. Really, it's understanding how each client need is different. Criminogenic factors are very different. We take into perspective their upbringing, their access to resources or lack of access to resources. And so I really enjoy working with individuals who have like PsyDs or doctorates, so where I can really pull research and learn more from what I can, because I do only have a master's, but I've been very privileged to have access to individuals who support that and integrate that. I think that the downside is that there's not a lot of clinicians that want to work with this population. There's a lot of research, and there's individuals who want to really bring in trauma-informed care, but in terms of execution, there's very few providers who want to work with individuals who are convicted of sex offenses. So caseloads are high, but that's been my experience over the years so far.
Great. Thank you guys so much for sharing. The next question that I have is, what should clinicians be mindful of that oftentimes goes overlooked with this population?
I can go first. Working in the criminal justice system, I think that we've seen a lot of change, but not fast enough. There's been a very retributive history in the criminal justice system, and not necessarily looking at the person. Instead, we generally tend to look at the crime. And so what I believe is important for clinicians, and when I was an officer looking at who I wanted my clients to be treated by, I really wanted the focus to be on the trauma that started from birth or in utero, because I strongly believe that most people who commit crime are driven by criminogenic behaviors sustained because of trauma. Poverty is very high. Not everyone can afford a very expensive therapist or psychiatrist. One of the best therapists I've ever worked with give a lot of care in the moment, but they also teach them self-care, self-soothing behaviors, meditation, mindfulness, things that they can do on their own without calling someone if they need to, without having to pay an extensive amount of money, especially with parents who have juveniles who are involved in the system. That can be very expensive for them. So the poverty is important. I also believe when you look at the prison mentality, there's taboo in getting therapy or looking at what makes you fragile, looking at your own victimization, especially if it's been sexual victimization. So understanding that you're asking men and women who've had to suspend their emotion and suspend having any type of emotional response in a very strict population or environment, that it's going to take them time to find those emotions again, and to be patient with that. And then I think the other thing is the criminalization of skin color. We have to move away from a system and acknowledge the fact that clients of color have been criminalized since birth. They have PTSDs related to race. They've been denied services because of their race. And so to be more racially informed, not just trauma informed, I think is extremely significant when it comes to what clinicians should be mindful of.
I wanted to add to that. So my first thoughts when I heard this question was about the effect of social inequality on interventions. And we live in a socially inequitable society, and so that affects the types of responses that the criminal justice has. Even though equality is one of our values, it's still tainted by this inequality. And it also affects the decision-making that victims will make when it comes to when, how, or if to interact with the criminal justice system at all. And then once someone gets involved in the criminal justice system, it doesn't mean that they're necessarily automatically safe. So a lot of victims of intimate partner violence or sexual assault who have minority partners may try to limit their contact with the criminal justice system because they're afraid of discriminatory mistreatment of their partners. If they have had contact with the criminal justice system prior to this on their own, they may want to avoid mistreatment of themselves. Also, abusers sometimes use the criminal justice system as a tool. So if they're very savvy about things like mandatory arrest, they may, for instance, bruise themselves to have some sort of evidence of physical violence in order to have their partner arrested. And then sometimes abusers will also take advantage of their partner not knowing very much about the system. Like, well, if you call the police, I'm going to have you deported, and that sort of thing. So, yeah, basically to build off of what has already been shared, just an awareness of how social inequality affects how, when, if to get in contact with the criminal justice system.
Yeah, absolutely. There's so many great pieces have been shared. I think as a clinician therapeutically, what I'm very mindful of is that piece speaking to looking at the person and understanding the person, their experiences, and really not typically when I have an intake, I'll take a look at their collateral. That's important, understanding their offense, just their history. But when they come in as them, and I see them as a person first. A huge part or barrier to offense specific work is the clients have that label, right, of being a sex offender, and they really struggle with that. So we very much work on differentiating that for shame purposes, right? Like, this is a mistake, it was a choice, and it was very impactful, and it was abusive and hurtful, and it doesn't mean you're a bad person, right? So we very much deconstruct that. The second piece is it's mandated treatment typically. And so when they come in, they're usually very hesitant depending on their interactions with the criminal justice system. If they've, especially in terms of cultural competency, if they have been mistreated, if there's racial factors or trauma that has been included into their history. It's a very dynamic process when you're doing intakes, at least for me. That's how I approach it, very, very subtly and very therapeutically. Because if the relationship's not there to continue to build so they can feel safe enough to talk about those pieces, then we're not going to make that progress in treatment. We're not going to make behavioral changes. They're not going to be open to the coping strategies that I offer, the trauma work that's offered. And so it's very much about that therapeutic relationship, but understanding that if there's resistance or pushback, it's often because of those built-in barriers from the experience of the criminal justice system and the distrust of others or authority or their perception of authority. And so having to work through all of those domains and dynamics is very crucial. But the first piece is that trust building phase and understanding that they typically don't want to be there. Some clients do, but some clients don't, especially if they're in denial or if they have a significant history of hands-on sex offenses in addition to DV offenses, and then you're integrating both treatments. And so I think as a clinician, being very mindful that they're human first, and that's where that relationship and that progress is really going to come from.
Great. Thank you guys so much for sharing. The next question that I have, you could answer one part, both parts, or the other. What are some challenges and or areas of strength you have observed in working with clients from this population?
The strengths and challenges I've observed were both related to help seeking. So there's models of IPV help seeking that are out there, and it suggests that most people will acknowledge their victimization prior to seeking help. But in the research that I've done, I found that's not always the case. People often seek help prior to recognizing that they're being victimized. And so it's basically a process. It's partially a social process where you're speaking to friends, you're speaking to loved ones, you're speaking to clinicians, and so on. So depending on what they think of the problem as at that moment will affect what they report to you. And that can make it very difficult for you to provide appropriate referrals, to intervene in a way that's most appropriate to what's going on. I also, in my research, found that people reported that a lot of times it was a counselor or a therapist who first planted the seed in their mind that something wasn't right, that this was not normal, this wasn't regular relationship conflict, but instead that there was some sort of imbalance of control and power, and that the behavior or the relationship itself could be abusive. So I think it's important to recognize your role in that acknowledgement process. So when it comes to strengths, one of the things I saw was that people were always trying to get help. So even if they labeled it as relationship conflict and not intimate partner violence, they were always seeking help. Again, that brings up the challenge of when they're saying to you, I'm here for a relationship problem, I'm here for couples counseling. Couples counseling may be inappropriate when you have such a power imbalance. So basically the strengths and the challenges stemmed from the same root, which was help seeking and where they were in the acknowledgement process of victimization.
Just to add to that, one of the strengths I consistently see is resiliency with clients. Despite what they go through and what they've been through, starting in childhood, just the resiliency they have to get through the system, to get through the day, to get through their obstacles, to get through their fear, their traumas is huge. And for us to acknowledge that resiliency and honor that, I think is extremely important building that relationship that was spoken about earlier, establishing that rapport. Challenges that I see most often have to do with coerced mobility or forced mobility, in the sense that there's a high homelessness population. It's very difficult to get them the services that they need. It's not like you can go to their home and offer in-home services. It's not easy for them to show up to your office when they don't have money or transportation to get there. There were times I've worked with clients who didn't know what day it was. So to tell them to show up at your office at 3 o'clock on a Tuesday doesn't always, it can be challenging, because they are really struggling with living in the moment. And when you're in that much of a survival mode, that challenge in and of itself can be really difficult when you're trying to get them to the services that they need. And obviously that comes with poverty. A lot of them have broken or have really burned those bridges with their support systems, or they just don't have support systems anymore. So getting them the therapy that they need, putting them in an environment that's conducive to change or sustain change, can be very difficult, because they just don't have the support systems that maybe you or I have, that, you know, would really help us to get to that point. I would also say, and I've said this before, is the fear that they have in the system, which we've all acknowledged in each of our presentations here. They aren't trusting of the system, and there's lots of reasons why they shouldn't be. You know, you mentioned immigration. There's been a lot of clients who won't even call the police because of the fear of deportation, the lack of understanding their resources, and really what has been kind of put in society through media or through whatever social media in regards to what can happen to anyone who contacts the system, who may be of color, who may not have a documented status here. So I think that those challenges are mindful, or are things that we need to be mindful with when we're working with them, that they're really deplete of a lot of the basic foundations that we need to get them to where we need to be. But the beautiful part of working with them is that resiliency, that desire to want to get better, that desire to want to be accepted and loved, that desire, maybe even that tiredness to not even be in the system anymore. They're just tired of what they're going through. You really can capitalize upon that resiliency and help them to see their own resiliency to get them through some of those obstacles we may not have any control over.
Yeah, absolutely. One of my first notes was resiliency. I see a significant amount of that with clients that I work with. Their adaptability, their ability to have, introspection and self-analysis. They want to invest in learning about themselves and their behavior, about their trauma, about family dynamics, just all of those domains that go into how you think and how you feel and how you build your belief system, your value system, the choices you make. And I've really appreciated working with clients who are willing to do that. I would say on the flip side of that, in terms of challenges, is clients who present with denial. Obviously, it's for protective reasons, right? And we recognize that as therapists, like, what's the purpose? How is this serving you? So having to work through that denial and those self-preservation techniques that they have, I would say, is pretty challenging, because that places more barriers with what kind of support system are you going to have? Are you letting people into your life? Are you being honest with people in your life right now to be able to support you? Are you being secretive? Are you being secretive with your behaviors of reverting back to using substances because that's what you know, which then in turn ends you back, with a new charge. And so it's just so many dynamic factors to consider, especially with trauma, substance use, maladaptive coping. One of the biggest parts of research that I've done with my agency is Dr. Gary Reeser, who currently owns VETS, that I work with as my supervisor, talks a lot about the good lives model. And the good lives model talks about different domains in your life. And I'll summarize it, but the domains in our life, including relatedness and relationships to others, sex and intimacy, knowledge, learning, and knowing, agency, all of these core pieces of who we are, and what primary needs are not being met. And are we taking shortcuts to meet those needs? Are we meeting them in healthy ways? That goes back to, well, when we're younger, are we taught how to meet them in healthy ways? Are we given access to resources to have them met in healthy ways? And essentially, if not, we're going to take shortcuts to meet those needs, right? If we're in pain and we're experiencing trauma, if our learned behavior is to reserve and cope on our own, maybe we use substances, maybe we use sex to cope, maybe we use various things, right? So I think the challenge is working through clients who aren't ready to quite address any of those pieces. And then that can just make it more difficult if there's lack of accountability to enhance, victim effective language, right? Having victim empathy rather than victim blaming, and then working through more of those abusive traits or tendencies, especially if there's DV included in that. So I know that sounds like quite a bit as I say it out loud, but hopefully that makes sense. Those challenges and strengths can definitely counterbalance each other.
Thank you. I feel like this is personally so insightful, and I'm learning a lot from y'all so far. The next question that I have is, as a clinician, have you had any interactions with clients involved in the criminal justice system that have changed the way you perhaps approach other clients or people in general?
I started working in the criminal justice system in the very late 80s or the early 90s. And unfortunately, I think a lot of the training had to do with treat the crime, retributive responses. And fortunately, as I matured in my career and became more educated, and our system has really pushed forth a change, I strongly believe that my own professional transformation has been that trauma drives criminogenic behavior. There's these theories that pure choice, just drives criminogenic behavior. And although there might be something to that, I think that there's other environmental and biological factors that we need to look at. Looking at adverse childhood experiences, offering childhood or trauma-informed care, again, is really more of my focus when I work with clients, especially education, higher education. I think in society, sometimes we still look at higher education as a privilege. Not everyone has this equal access to education, yet education can reduce criminal behavior by 72% alone. And so it's something that has truly changed the way that I work with clients. And again, seeing them as human beings who have made mistakes, who, like was mentioned earlier, who have learned those negative coping mechanisms in childhood that need to unlearn them or really address changing those. But I think the way clients have really changed me is to really understand that they're people first, and that there's a tremendous amount of trauma that they don't speak of that drives their behavior. And I think when you acknowledge that and you come with that demeanor towards them, you're able to gain a lot more rapport and respect with them to get them to address a lot of the things that they don't want to address. You had mentioned denial, which is huge. I forgot about that until you were talking about denial. It's just that shame of admitting some of the things that you've done, or that you just are really struggling with addiction. So the more holistic we can be, the more that we can offer an environment that sees them as human beings in need of help, can really be transformational to them. And I'm really grateful that in working in the system from a very long time ago to now, clients have taught me the majority of that changed behavior in myself, that changed mentality.
Right. So my experience working with clients has been in two main areas. One was on a crime victims hotline. And then the other was working in a community center with a victim assistance program. And so when people contacted these places, they already had some sort of sense of themselves as being a victim of intimate partner violence or sexual assault. Even then, there was still a lot of minimization. There was, and I don't know if this was partially denial or because it's quite threatening to think of yourself in this way, or it could also be a social issue. So there's different ways that we define what victimization is. And often when we look at other people, we use a very expansive way of defining victimization. So when we look at other people's situations, if there's any form of violence, we say, yes, they are a victim of intimate partner violence or whatever sort of violence you're looking at. When we look at ourselves, we look at our experiences within a context. And so we redefine what went on based on our relationship with that partner. And so because of that, people may be less likely to recognize the violence early on, because this person is not just someone who hit us. This person is also someone that we've raised children with, that we've shared holidays with, that we've had all these wonderful experiences with, and that influences how we interpret what's going on, how we make sense of whether we're experiencing victimization. So because of that, one of the ways it's changed the way I approach other clients is just that whenever there's some discussion of conflict, I always think there's the possibility that there's far more going on than I realize. So I'm always on the lookout for intimate partner violence. So maybe, I mean, I don't want to say I hunt for it, but I guess in a way I do. Another thing was, like you mentioned, resilience. So a lot of people who I've encountered have tried many, many things to counteract these problems. And so when I have met with other clients, so I've also worked with non-traditional students in a student support program. So when I would see different challenges that they were always trying to work against, I always would kind of hunt for IPV in that sense too, because sometimes that was something they were dealing with, but they didn't recognize it as one of their presenting issues in the college context. They just thought of it as something that was going on elsewhere. And so those are the two main ways it's colored how I interact with other clients.
I would say for myself, just being so immersed into treatment planning and really seeing clients through the therapeutic process, it's been taking time to learn from them, right? Just really understanding their history from a holistic lens. What are your experiences? How do you think? How do you feel? What's shaped you? What have you learned from? And understanding that the reality is there's going to be clients that are receptive to change and that it's going to be much more difficult for others. So patience is huge, like learning patience and shifting my treatment approach and really understanding that it's not about me. If I don't click with the client, that's okay. It's okay to refer. It's okay to have other clinicians see if it's a better fit. Like for me, for example, understanding that clients who present with more DV tendencies, I do have to really change my approach versus clients who don't, just because those characteristics are very different. And so I think being really self-aware as a clinician of if there's something coming up for you in session to talk about it, to name it, to really process through it, help you and that client communicate what's going on in the room. And that's okay, because the dialogue is so therapeutic and can foster so much change, or at least plant a seed. And I think that's been my experience, is just if there's something in the room, naming it and changing your modalities or your approaches as needed, and really staffing personally in this field staffing with the team, right? It's called a community supervision team. You have a probation officer, a parole officer, a polygrapher often is involved. And then just your colleagues, right? I'm personally right now in my sense, I'm very independent, but I have access to many people. And so just understanding that it's okay to ask questions and it's okay to learn as you go, but you learn so much from your clients and you're not always going to have the answers, and that's okay. So that's what learning is for, and asking questions and consulting people who are in the field is really, really important.
Great, thank you all so much. The next question that I have is, what do you wish other clinicians knew in regard to working with this population?
Yes, I'll go. One of the things I hope for clinicians to always keep in mind is that their client is someone who's within a social and cultural and political context. So because you're dealing with an individual person at one time in one session, you might be tempted to view their experiences as isolated, but their social interactions, their cultural context, the political context is always going to influence the types of decisions that they consider appropriate to even think about, the types of responses that people will give them. And so we should always be aware of that, because without understanding that context, things that they do may not fully make sense to us. And if it doesn't make sense to us, how can we respond appropriately? So for instance, there's this stereotype that victims of IPV are very irrational. Why would she do that? Why doesn't she just leave? And this and that. And even though we may explicitly reject this stereotype, just being a part of this society means that on some level, we probably hold this stereotype implicitly, right? And I do think that this stereotype is informed by misogyny, as most victims of severe intimate partner violence tend to be women. And so, and then you'll see abusers use this, right? They use this to manipulate their partners. Well, you're just crazy. You're like this, you're like that, and use it to dismiss them. So when you're in session with a client, that should be a place where this stereotype doesn't inform our own reaction to them. So if we know that we may implicitly hold this stereotype, we want to be careful that we don't act it out in the session, therefore carrying out the same sort of abusive behaviors that they're experiencing in their relationship.
I would say it's very important working with specifically clients who've been convicted of sex offenses, because as I had said, there's very few clinicians or therapists that want to do that work. I would challenge that in the sense of understanding your own personal bias, understanding that there's a reason for behavior, right? It's not excusing that behavior at all. But what that's telling you is that if it's learned, it can be unlearned, and there's change. There's also other varying research with criminogenic factors and genetics and things of that nature. I'm just really asking to, have clinicians take into consideration, could I work with this population? Maybe you do an internship, maybe you just do shadowing, right? Get curious about the field, because there's so much amazing work that happens, and clients who can complete treatment or at least have completed some treatment, it reduces the risk of recidivism at least by 33%. And so having someone who's involved and invested in them is huge, because many of them have not had that. So if you're willing to sit with them and process through such a dark time in their life as well, probably one of the most dark times in their life, and helping build that back in a way that feels pro-social and connected can significantly change their scaffolding moving forward and building a life for themselves on top of those other domains. However, stigma and personal bias and belief systems can potentially hinder other clinicians from wanting to do this work. I had an intern who was in that same playing field, and she tried it and she loved it, and she found out that this is something that she wanted to do in her future. And so it is challenging work. There's a significant amount of paperwork you have to do. It's different than general mental health, but it has challenged me on so many levels. And I've met wonderful doctors and doctors of psychology, and I've been involved in research that I've had opportunities that I wouldn't have had. And so I think that within this field, it can challenge you in ways that I personally didn't think that general mental health could. If you can work with clients in the criminal justice system, I wholeheartedly believe the work you do in general mental health will be explosive, and it will be great. And you will have so many new tools to use, because it's just different, and it's dynamic, and it's challenging, and it's hard work, but it's really honestly very rewarding.
Just to add to what they said, that I honestly believe, from an officer who would send clients to receive therapeutic services, one of the areas that I wish clinicians would understand, and maybe they do, and I'm not necessarily aware of it, but I always wanted to make sure clinicians understood that the practicality. It's very difficult for them to get to you from 8 to 5, or to report for in-service or rehabilitative services at 7 in the morning when you're addicted to fentanyl. The practicality is making your office hours accessible, being in the community. One of the things that I loved about being a probation officer is I was in the community. I went to their homes, and not to be intrusive, but if it avoided a single mother with 3 kids taking 3 buses to get to me, to help her with successfully completing the conditions of her supervision by me going out to her house, that's something I would do. Not showing up at 8 a.m. expecting someone to have to take a full day off of work when they desperately need that money is really important. So the practicality of therapy, offering therapy, being more mobile, being more after hours, weekends, being willing to go into homes and not only offer therapy just for that client, but also whoever is in that home. One of the things that I always tell my students a story where I had a client who was addicted to marijuana before marijuana was legal. And she met him when he was high. She married him when he was high. They had children when he was high. We put him in intensive therapy. He became sober. And she called me one day and she's like, you need to let him get high because I don't like who he is sober. And, it really made me realize that as they're transitioning, that support system also needs to transition with them. And it's really important for clinicians to be really aware. I almost make it sound like you guys have to be superheroes, but in my eyes, you are. You just have to be so much more. I'm not saying you're not, but there needs to be this awareness that in order for someone to truly change everything about them, there are going to be changes in their communities that may be resistant to it. Helping a man who has been convicted of domestic violence change his behaviors, take time out, do the things he needs to. We also need to get the victim up to speed onto those changes that are happening. So there's this, broadening the scope of the therapeutic patients just attached to that one person, I think is really important to know. The practicality of offering therapy based on hours, transportation. I know you have to get paid. I know, but somehow finding a way, in addition to offering your services at the rate you deserve to be paid, doing those things of mindful meditation, teaching them how to self-soothe or have self-control and self-regulation in the moment when they might not be able to see you, I think is also very important. And again, understanding those generational cultural pressures. I know my father, he was in the Vietnam War, he was drafted, and for years, in his mind, men don't get therapy, Latinos don't get therapy. And it I feel like sometimes it destroyed him. And so it took him a long time before he finally even accepted that therapy was okay. And so having understanding that in order for them to get therapy, they're having to break down their own barriers, generational, age, family, culture, to get to that point. And I honestly, sometimes I don't even know if they know how to do that. When I work with men leaving prison who've been in prison for 30 to 40 years, they're so out of tune with their own emotions and how to even address those, and getting over this prison mentality that they have to stay alive. Uh, those are things I don't think you would expect anyone to know, but it's always certainly okay to ask. As clinicians, we can't know everything. We certainly don't know what it's like to walk in their shoes. And I've had plenty of conversations just as an officer saying, help me understand that. Help me understand what that was like for you so that I would know more. So, understanding those cultural pressures, I think, is very important. I also believe, and I know I said this before, so I won't say it too much more, but when you look at statistics in books, victimization, they always give statistics. And I honestly believe in 25 years of working one-on-one with clients, I do believe victimization is much higher. I'm willing to bet it's 95% or higher when you look at childhood victimization, when you look at structural and systemic discrimination on any level, whether it's LGBTQIA, race, socioeconomic, that we have to really broaden the scope of what victimization is for people and to honor that victimization, because that is not just what specifically may have happened to them, but just the broader perspective of victimization really does help that holistic healing to occur. And I definitely believe clinicians get that better than most officers do. And so there's also a component of me that's like, as clinicians, don't be afraid to call officers and teach them. I became a good probation officer because clinicians called me and told me to stop doing certain things. Or helping me to understand things or inviting me to therapies. So when you need to broaden your support and you don't feel like you're getting it from the supervising community officer, don't be afraid to make those phone calls to get them on board and to teach them things that they might not know.
I actually really appreciate what you said about the pro-social aspects of like stability factors, employment, their resiliency with family, connectedness to family. Do they have a support system, right? Do they have people who you can bring in? Systemic work really happens in offense specific work because one, especially relational work, if they have a partner, it's really important we're understanding healthy relationships, boundary systems, where they learned or did not learn boundary systems, communication, and then also offering accessibility, right? Like in offense specific work, I will be honest, I work later. It's either early mornings and or nights. It kind of just depends where it is. You can make it work, but being mindful of providing time for your clients is really important. And I have went to many probation and parole meetings with clients just because the clients, in terms of compliance, if they're struggling with something, they will want to be honest with me in treatment, but then they fear repercussions or being sent back to a judge or court. And so then that secrecy sustains. And so then you're put in a position as a clinician to really mend and say, I hear you, and I absolutely appreciate honesty. How can we work together so we can learn from this so that we don't have to have enough violations to get us sent back to court? And in reality, you're the biggest advocate for your client, because at the end of the day, if they don't get discharged from treatment, you can still try to do some work with them and provide resources, because they're not going to get that if they're back in jail or prison. They just go back in front of a judge or get resentenced. And so being really mindful that you're the biggest advocate for them, even if, you know, at the end of the day, if they have a new offense or a new hands-on offense, your hands might be more tied. But if it's maybe they viewed pornography, maybe they had a lapse on marijuana or cocaine, maybe they some form of non-compliance, but that is an opportunity for learning. It's an opportunity for growth. So just to build on that.
Thank y'all so much. I think for just to respect everyone's time, I might just ask one more question and then leave it open if anyone else wants to add any questions. I know one of the questions that I sent y'all previously was if you have any resources for working with this population, because we are all mainly like counselors in training. So any like research articles or anything that you find is helpful, if you wouldn't mind either putting in the chat or emailing it to me, because I have a SharePoint and I'll put all of those like readings and clips and things like that up there. So I'll probably have to skip that question to respect everyone's time, but I do want to ask the last question that I have, which is if you could give one takeaway to aspiring mental health professionals like us, what would it be?
I would say that context is everything. So just being aware of social, cultural, political aspects of whatever problem it is that you're looking at will help you provide the most appropriate response.
From a personal perspective, as a clinician, be yourself, be genuine, be who you are, the way you are. Don't feel you have to be like someone else. I learned when working with clients, if I tried to be who I admired the most, or if I tried to be like someone I didn't like the most, or who I thought was the perfect type of person in my head, it never worked. And until I allowed myself to be quirky and be exactly who I am, that genuity goes a really long ways in establishing that rapport with clients. So be the best of who you are, exactly the way you are. I've learned in working with people, men and women in prison, is genuity is like their higher sense. They can sense it within seconds. And so being genuine, being yourself, allowing yourself to make mistakes, allowing yourself to know that you're never, ever going to know everything all the time. It's okay. We allow everyone else this huge ability to make mistakes and to to correct their errors, but we're very hard on ourselves, and we expect ourselves to be a specific way all of the time. And looking at my career and being in it for 25 plus years, you're not going to make it 25, 30, 40, 50 years if you don't allow yourself the same self-love and the same compassion that you give your clients, and that same opportunity to understand that there's just times you're not going to handle a situation perfectly, or you're not going to know the right thing at the right time. But that's okay, because time is on your side and you can go back and make it up, and you can do things differently the next time. And that self-love is almost a self-preservation to make it. You're going to deal with an enormous amount of trauma working in sex offender units, domestic violence units, gang units, looking at child abuse, child homicide cases. You deal with so much trauma, and we don't want to take it home to our family. We don't want to further victimize other people by the things that we have, but we have to have an outlet. We have to be able to have someone we can talk to. We have to have the same self-care so that we are always strong enough to continue to do our work that is so important to us. Sometimes we're willing to compensate what it means to us because it's our passion, and we can get over it, and we're also resilient, but it adds up. After years of working and denying your own trauma and holding it in, or thinking you're the professional, that you somehow are immune to secondary trauma, it'll catch up to you. that lack of wellness within you is gonna manifest in your own body, your own practices. So really making sure you take care of yourself is another really bit of advice that I would give you, because I mean, this is your career and this is what you do all day long, and you're going to do it for years. And so really take care of yourself and give yourself the same compassion and love and acceptance that you give others.
Yeah, absolutely. I think that's something that's very overlooked is self-care. Setting boundaries in this field is significantly important for your own mental health. And in the beginning, you might feel guilty about that, but understanding like that gives you some time for introspection and asking yourself kind of what's going on there, because you're deserving of that time. This is really tough work. There's a lot of vicarious trauma that can happen, especially if you're dealing and processing your own trauma. I also would encourage you to embrace discomfort. You're going to have uncomfortable conversations in this field, and that's okay. The genuineness is huge. I do want to, yes, absolutely. Genuineness is huge because the clients, that building that relationship with them, they can tell the second that they walk in there if you're for them or if you're unsure of yourself. And they can sense that, and being genuine and saying, yeah, I'm human, I make mistakes. I tell my clients that all the time, I'm human, it's okay, I did miss that, I'll correct it, like we'll get it taken care of. And so accountability on your part, demonstrating that humanness or humaneness, I think is a protective factor for them. They typically lean into that, while also having healthy boundaries, right? We are human and it's important to take time for self-care. So I would say that those are the biggest pieces I would suggest.
Thank each and every one of you so much. I feel like this was super insightful and informative. I did want to leave maybe like a little bit of time to see if anyone had any personal questions. I know it is 1 o'clock, so I do want to respect everyone's time, but if there are like 1 or 2 questions. Cool.
Oh, sorry. I have a question real quick.
Go for it.
First, thank you all for sharing that. It was really insightful. These therapies or these practices are happening outside of the incarceration. Are there services within the system they can receive, like maybe while they're being processed or after they get their sentence, to kind of prepare them for when they exit?
I would say that depends. So typically clients who are sentenced or convicted, and let's say they go to the Department of Corrections who serve prison time, there is a service called SOTMP specifically for sex offenders, but that program, there's various stipulations under their sentencing guidelines that either will prompt them to get treatment or will put them on a wait list. They're significantly backlogged. However, when they're able to get treatment for sex offense work within DOC, those are basically the building blocks prior to being released to the community. It's significantly depleted from my experience. In terms of other mental health services, I do know there's clinicians shortages within prisons or jails. But in terms of sex offense work, I do know that it is offered, but it's significantly difficult to receive.
I'll just add to that by saying absolutely, there's such a lack of resources when a person is incarcerated, whether it be jail or prison. There's also the practicality of if you're only in jail for 2 weeks and you only have good time for a certain amount of time, or there's no lockdowns, if there is someone who can help you, it may be very limited. Prisons are the same way. With the resources that they have, most often it's for the people who will be released within the next 3 years. But trauma happens even in being incarcerated. I mean, there's statistics that show that people who don't go in with mental health illnesses certainly leave due to the trauma that they face in being incarcerated, being in administrative segregation. So there's definitely a lack of resources. There's a lot of turnover with professionals that are able to even get into the prisons and work there. One of the things that I really have always suggested, and I'm a strong advocate for, is providing the academic services and resources to train men and women who are already in prison, who may be serving life sentences, who might never be getting out, train them and get them certified in trauma care so that they can provide their own services to other people while they're in there. Peer group types of therapy would be really important to help people who are in prison. So if we can't get the resources in there, look at being really creative by training people who are serving long-term sentences, who have probably learned quite a bit, who are ready to make a difference in that population. Looking at services online or in internet type of therapies so that we can get those services to them, even if we can't get it within the prison walls, I think would also be really important. But no, I 100% agree that there's just not enough services available to people who are incarcerated.
Thank you so much.
Great. Well, I think if there's no more questions, thank you all so much. I'm gonna stop the recording